Our next session is a panel discussion on management of asthma. We have Professor Rajagopalan to moderate the session for us. The panelists are Dr. Venugopal, Dr. Dhanashekhar, Dr. Thangavel, Dr. Emmanuel Bhaskar, and Dr. Sumati. I request the panelists to come up on stage. Dr. Thangavel is a consultant pediatrician and head of the Department of Pediatrics, Mehta Hospital, Chennai. And he is specialized in pediatric emergency and intensive care. He has a great passion for teaching and has trained many pediatricians. We welcome him to the panel. Emmanuel Bhaskar is the Professor of Medicine, SRMC and RI. He is a founder and co-editor of Database of Medical Research in India. So we welcome him also. I now hand over the session to Professor Rajagopalan to.
This asthma, this session is an important session. See, such a common condition we see in our day-to-day practice. In India, if we say asthma is grossly, I will say, underdiagnosed, and even the diagnosed cases are not getting the optimal therapy. There are no statistics, Indian statistics, how many percent of Indians have asthma. But somewhere around Jindal, I think Jindal, is it? Yeah, he has done a study wherein he says about 2 to 3% of the Indians are asthmatics. 2 to 3% means such a large number when you are having such a huge population. Nearly 20 to 25 million asthmatics are there in India. But if you compare it with the drugs that are sold for asthma, mainly the inhaled corticosteroid sales, it doesn't reflect. If you really, there was a statistics that says only about 15% of the asthmatics, they receive the treatment, what is to be given for them. So where is the problem? The problem is lack of proper understanding of this disease. I want this session to be more interactive. From morning there were no questions at all, at least we were fortunate to get 2 3 questions. It is good. Probably if only for ladies they will ask questions in this audience. So I will expect some more questions in this session. We will start like this. Well, how do they present to a general with Dr. Emmanuel Bhaskar? Is one of a senior most professor. He has a passion for teaching. I think he should be the right person to start the proceedings. Just you may discuss about the symptomatology by which the patient comes, an asthmatic. They come with varied symptoms, not that everybody comes and says, I have asthma, I have wheeze. Can you start with that?
Yes, sir. I think it's correct that you started with physician, because now if you look into the presenting features of bronchial asthma and the competency given at the level of the undergraduate and even at the level of the physician, a substantial proportion of patients are in fact overlooked because they do not present with, as sir told, with a typical history of wheeze, or when they have a wheeze, when they actually come to your outpatient visit. So can I just put back the question to you? And what are the symptoms with which you will suspect bronchial asthma? When will you clinically suspect bronchial asthma? I just want one volunteer. Just start the answer, few sentences, then I'll give my inputs. Yes, please. You can just please. Yes. Cough. When the patient comes with breathlessness. Now, what is the pattern of breathlessness you'll be looking for in bronchial asthma? Now, for example, in cardiovascular condition, you think of exertional breathlessness, isn't it? What is the pattern you look for in the breathlessness? It's a very common complaint, breathlessness. Yes? Nocturnal breathing difficulty, excellent. 1 point. Anything else? Seasonal, excellent. One more. No, patient do not see their accessory muscles actually. Excellent. Allergen dependent breathing difficulty. To some extent when there is a background of family, but current symptom I am asking. Few you have brought out, nocturnal breathing difficulty. Anything else? When there is atopy, allergy, almost we can put together. Exertion dependent, fine, you have told everything. Now, can you just tell me few situations where you can miss a patient with bronchial asthma? And the patient comes with all these things, seasonal. I get dyspneic during seasons. I get dyspneic when I'm exposed to these things. When these are the presenting feature, you will diagnose it, right? So can you tell one or two situations where you will miss the diagnosis of bronchial asthma? Excellent. The cough variant. Okay, it's extremely overlooked. These patients are repeatedly prescribed just cough. Can you add to the cough variant? What are the pattern of cough you will suspect? Cough can be non-specific. I just sit for some time and just brief episodes of cough and going off. Is there a pattern you look for? Dry cough, predominantly in the night. Episodic cough. Then? So all these triggers associated with just a cough. Patient may not even tell the breathing difficulty is there. So cough variant asthma is probably I will rate as one of the most important symptom which we really overlook. One more situations where I can tell is that the non-specific description of a chest tightness, right? So maybe more and more proning, more and more asking questions, maybe it will clarify to some extent. I think now sir can put more inputs into that.
Exactly, you have started it rightly, doctor. See, if you look at the definition, the definition has changed over years. When we studied, when Dr. Venugopal, Dr. Thangavel, when we studied, asthma is characterized by episodic wheezing due to allergen, which changes its severity with or without treatment. That was the definition given in Davidson when we studied in 70s. But now the definition is totally changed. You have a GINA guidelines which states everything what Dr. Emmanuel has told. It is characterized by wheezing, chest tightness, cough, one more thing they have put, and physiologically by airway limitation, which is reversible, totally reversible, pathologically by the, all forgotten, airway remodeling. Increased vascular permeability, excess mucus production, muscular hypertrophy resulting in airway remodeling. Okay, so even the definition, if you read this latest GINA definition, it tells whatever, so that you don't miss anything, right? So next question I will put up to Dr. Tangwele. How do you see, the children, because here the children is a group wherein they don't have a symptom. They don't come and tell to your, when they come to your room, they don't complain. It is more the mother or the parent who gives the complaint. How do they present?
Thank you, sir. Thanks for the opportunity given for me. It's almost like a veterinary practice only. The patient doesn't talk to us. Only the mother tells her it is up to us to identify. This is overshadowed by other issues. Like for example, in adult, Dr. Emmanuel very clearly, very nicely displayed all the points. Almost most of the children also present with chronic cough, particularly prolonged cough, nighttime cough. Incessant, the child is sitting in the outside in the OP, you can hear the sound, continuously will be coughing. On other occasion, children also has viral fevers most commonly in the initial first 1 or 2 years. So we don't give the label of asthma in the first 1 year. It is clearly defined as under 5 weeks because there are many reasons for which they can come for similar symptoms like cough. So all the symptoms described in adult like chest tightening, or episodic cough, and continuous cough, nocturnal cough, feeling of chest tightness, all this can occur in older kids. Younger kids, mostly they present with cough. Mostly following respiratory infection, cough doesn't settle down, starts like an URI, the cough continues for about 2-3 weeks. We suspect two things, either the postnasal drip causing cough or the probably is developing an episode similar to asthma. We don't label as asthma because unless the child develops more than 3 episodes, it's not labeled as asthma. But more commonly, we exclude serious condition associated. Like even 2 days back, we had a child who presented with respiratory distress. 1-year-old child referred as asthma, but there was an auscultation, there was a diminished presence on the whole of left side, which doesn't occur in asthma. Asymmetric findings will not be there. When we probed the history, we were told that other siblings along with the child were eating groundnut. So groundnuts, pediatricians are always allergic to groundnut, because any groundnut intake below 5 years invariably rolls into the bronchus. So it gets logged on the left mainstem bronchus. Our pulmonologist identified by the fiber optic bronchoscopy. It was removed, it is gone. So initially what was thought as asthma, first thing a pediatrician will look into the problem to see whether it's really asthma, or are we missing a cardiac failure, are we missing a GERD, are we missing a foreign body. We'll have a lot of other asthma mimics.
Right, sir. As Madam has pointed, she talked about exercise. Somebody said exercise-induced asthma previously when Dr. Emmanuel was asking. That's an important thing. Children, the mother usually complain when they bring the child. They say, oh, this fellow, when he goes and plays, he comes from school, he has his food, everything, he goes, plays. The moment he comes back, he starts coughing. You have to suspect asthma in that. It's very interesting. In a pediatric group, if I am correct, you will see more of male child affected with asthma. But when they become old, it becomes reverse. Adult pulmonologists, we see more of female asthmatics, whereas pediatrics, they see more of male asthmatic. It is not an observation. We have evidence for that also. I think Dr. Venugopal should tell about that. And one more thing for Dr. Thangavelli is, they say asthma, the child will grow out of asthma. It is all, I think it's not a correct thing. I don't find any child, because invariably they will say, when the patient comes and they say, no, the doctor told me when the child becomes 9 years, the asthma will stop. That, I don't know whether it is a misconception or is there any evidence for that.
That means a lot of other mimics of asthma are there in children. We diagnose more of non-asthma conditions. We try to find out. Probably a child who has got a family history of asthma, or a child has got an atopy in the skin, or a child has got a very clear history of exposure to allergy and developing wheezing. These children will definitely continue to be in that asthma circle. So those children who do not have family history, who do not have a skin allergy, who do not have a classical development of cough following exposure, these children probably generally they grow out of it. That's what we divide into two categories, sir. The category with skin allergy, family history, clear-cut exposure to allergic things, definitely they will continue to wheeze. Those who do not have these characters, most of them they come out of it.
Okay. And Dr. Venugopal, you should tell about this gender.
Yeah, before going to the gender, I just wanted to highlight on the previous thing, 1 or 2 points which I thought I should share with you. In young asthmatics, in children, so invariably when you go into the detailed history, the wheezers, they are cesarean born children. Majority of the cesarean born children, they go into wheeze. The reason we do not know. So the next time when you get a child with wheeze, you just ask the mother whether it's a normal born or cesarean born. Number 2, the people who carry the wheezing towards adulthood, as sir clearly explained, that if there is any atopic trait in that children like eczemas, allergic rhinitis, these children, they carry the asthma along with them as they grow. But there is one particular thing which you should understand, that if somebody develops, if a child develops a wheeze very young in their life, they usually gets it over in the childhood itself. But if somebody starts wheezing a little older age group, they carry their asthma along with them to the adulthood also. These are the 2 points which I thought I wanted to discuss with you. And majority of the cases which we see in the adult pulmonology department, asthmatics are females. There are many reasons for this. Probably ladies are more aware of their diseases and they wanted to have a checkup first and then come to the OP first, number 1. Number 2, the adult, they are so busy, they're busy in their work, they go out and they don't care for visiting the outpatient department much. So overall looking into, there is about, if you look at statistics generally, it will be roughly around 60% to 40%. Females are asthmatics, and majority of the asthmatics are having a atopic tendency like allergic rhinitis or nasal polyposis or such kind of thing, or eczema kind of things.
So, eczema, allergic rhinitis, all those things we can call it as comorbidities in asthma, madam. You should tell, because see, you have put up in the slide in the area also it says nearly 40% of the asthmatics, allergic rhinitis patient have asthma coexistent. Whereas 80% of the asthmatic will have allergic rhinitis. So I have to refer 80% of my patients to you, whereas you will be in turn referring only 40% to me. It's very, very unfair. You have to explain that, madam. Please explain.
Working in a private hospital, the number of patients that we see, I think especially the coexistence between asthma and allergic rhinitis is basically purely from referral. Now, adult pulmonologists, when they suspect that this patient is not completely getting better and also has some amount of upper respiratory symptoms, then the reference comes to us. And if we feel that this cough that we have been treating as tracheitis is not settling down, then we also feel that this is maybe a cough variant asthma, and we refer them back to you all as far as the adults are concerned. Pediatrics, they treat the patients initially. Most of the pediatricians treat them with leukotriene, and then they refer the patients to us if they are suspecting that the mouth breathing, the postnasal drip could be another factor for adenoid hypertrophy. Then the referral comes to us. So it's purely by referral, I think, that I've been seeing this concomitant combination between adults and pediatrics.
Most of the time the allergic rhinitis patients will be associated with bronchial asthma. There is there are a lot of studies says that there is a coexistence between allergic rhinitis and bronchial asthma, and most of the times they will present like a cough variant asthma. In that type of cases, you have to go for other investigations like pulmonary function test in that type of cases with cough variant asthma. And if you have a reversible airway disease with obstruction, then you can label them as bronchial asthma. And if you treat according, you have to treat in this type of cases, you have to treat bronchial asthma as well as allergic rhinitis with a nasal spray along with a long-acting bronchodilator, like along with long-acting inhaled steroids are helpful.
So, shall we go to the diagnosis? How do you diagnose adult asthma? Confirmation. Because not in one of the presentations said that every wheeze is not asthma. Same way, not all asthmatics they wheeze. Okay, and that's a thing. So, how do you make a final diagnosis of asthma?
This is a very valid question, because quite often we just assume that anything wheezes is bronchial asthma. And one thing I should share with you, that if you take the chronology of Davidson, the one thing which I really felt bad from the Indian perspective when I was an undergraduate as well as a postgraduate was that the diagnosis of asthma was actually costly, because you need a spirometry to be done, which has a complex technique to be followed. Reporting has a lot of problem and the patient has persistent cough. So the gold standard diagnostic test for bronchial asthma itself appeared to be complicated, at least for me. But there was a period where the National Institute of Health did a major study on correlating on-field testing in patients with bronchial asthma, and they actually, we should congratulate them for the global effort they have done, where they pushed in the peak expiratory flow meter in the point of care diagnosis of bronchial asthma, which is something a very positive move. And you can say in the last two editions of Davidson, peak expiratory flow meter has been opted as a possible thing as a replacement for spirometry. So from a physician, I think at the point of care testing, I think what you need to really look at is to look for a peak expiratory flow meter based testing. The problem is the sanity of the peak expiratory flow meter. You cannot really clean it, and though you have some adapters which can be sterilized, it's an area where I just want to share with you. Now, when you are going to have a clinical features, okay, you have suspected that it's going to be peak expiratory flow meter, you are going to decide on that. what you need to see is that when the patient has symptom, maybe you can encourage the patient, it's around 250 to 300 you get PFR meters which they can buy. And when the patient is asymptomatic at the point of care, you see the patient, they are telling the symptom and you're not able to pick up the diagnosis, the best way is to probably ask the patient themselves to check for the peak expiratory flow meter, get an instrument, teach them how to check for it and go for a diagnosis. And when they are in your place, easy method is to check for the PFR, give them a bronchodilator, see for a reversibility of 15% which is recommended Davidson. A very easy method as a physician I will tell, which makes the diagnosis less complicated. I completely agree that spirometry is still the gold standard, but my personal viewpoint is that it should be more simplified so that the point of care testing is made better and the patient is encouraged to use PFR monitoring on a routine basis to adjust his own symptoms rather than going into a clinic or hospital whenever he has a mild exacerbation which he can handle and diagnose.
What about you, sir, from the pediatric side? You don't have, you already told, it's more a clinical diagnosis.
More a clinical diagnosis. Emmanuel says, spirometry, we take it as a desktop computer. Probably peak expiratory flow is like an iPod, can carry it, more utility. But again, coming to children is very difficult because they belong to a special categories. But only beyond 6 to 7 years only we can ask the child to perform a peak flow meter. So we don't generally, may not be able to ask the child to use the peak flow meter. Only in an older child is possible. Younger children only clinical diagnosis. A child who comes with a respiratory distress or who comes with the incessant cough responds well to a bronchodilator therapy, preferably an inhaler therapy, either as a nebulization or through the spaces that show a good improvement. We can see the improvement within 10 minutes. The child clinically improves, then it indicates the child has got a reversible bronchoconstriction. Generally we don't rely on lab tests. Only that, as I said earlier, most of the time we'll try to find out some other cause, mimics of asthma. We have to go for either it's a foreign body or it's a congenital heart disease or a GERD presenting as asthma. For those sake only we may need an investigations.
Dr. Dhanasekaran, do you agree with Emmanuel's statement that spirometry is such a costly affair and a cumbersome thing? Because morning the presenter said, such a simple test. You are not
the pulmonary function test usually, I think the charges most, I think 1,000 rupees is the maximum amount I heard. I don't think it is, now we used to do around 500, there are places where they are doing for 300. Only thing is the filter is the most one which you have to change each patient. That filter alone will cost 100 rupees. So in that type of thing, I think under 300, 500 at present scenario is not that costly. And doing a cumbersome work, that is, you have to have a trained technician for doing a pulmonary function test. And we used to do in my clinic approximately around 10 to 15 PFTs per day. That's if the person who is trained to do a PFT can do it very simply, and we have to keep some video clippings before doing the test so that they can you can keep the two patients and you can show them and then they can reply the same thing in the test. And peak flow meter is also one of the nice device where it is also a simple device. Once the patient, sometimes if the patient is not able to do a pulmonary function test in that type of case, patients, we can do a peak flow meter. And in like usually you should for a pulmonologist it looks like a thermometer. So if you suspect in that type of cases, you change that for each patient. You can but mainly we use in the post-treatment scenario, where every time the patient comes, we cannot ask every time to do the pulmonary function test. In that type of situation where you can use that peak flow meter as a measure whether there is an increase after treatment can be monitored with the peak flow meter.
Dr. Venugopal should tell something more about peak flow meter in the day-to-day practice, and he can also give some his ideas about this pulmonary function test, because he was a second person in Chennai to have a spirometry, computerized spirometry. First was in Apollo, the second was by Surya Hospital, by under Venugopal. That is it. We started in 1980. So you should tell about your.
See, whatever said and done, the gold standard for the diagnosis of bronchial asthma is demonstrating the bronchoreversibility. Bronchoreversibility in the two parameters of the spirometry, two basic parameters, that is forced vital capacity FVC and forced expiratory volume in 1 second FEV1. If you have a 15% or more bronchoreversibility after the use of 2 puffs of salbutamol in FEV1, then that is the gold standard. That is how you say that there is a bronchoreversibility. So that is considered as asthma. Suppose if you do not have that reversibility at all, and you have FVC and FEV1 remaining as the same, and you are not able to demonstrate bronchoreversibility, probably you are dealing with a chronic obstructive pulmonary disease. So that is how you change the two diagnoses into each group. Now, this is not cumbersome. People who routinely do it can be done, and a very few percent, say I would say that in my experience for the last 20 to 30 years, maybe around 10 to 15% of patients may not be able to understand and do the pulmonary function test properly. The rest of the things people can do it very well. There is no problem at all, and the technician must get the best out of the patient. A technician, if you go into the details of the spirometry, there are two diagnoses in that. One is restriction and one is obstruction. And if the technician is not really taking out the effort from you, a restriction can become obstruction and obstruction can become a restriction. So that is the only problem in pulmonary function test. So you must be sincere, the technician must be sincere, then only the consultant can get a good test report. So that is regarding spirometry. And peak flow meter has got its own value. It is a very good tool in the day-to-day practice of bronchial asthma. You ask the patient to buy a peak flow meter, ask him to measure the peak flows at various intervals of time, in the morning, in the afternoon, evening and night, and record the peak flow values. Say for example, approximately somebody can blow, an adult can blow into 300 liters per minute. So that you keep on recording, 300 morning, 300 in the afternoon, evening 250, and by night it goes into 150 or so. So there is a drop towards evening or towards a drop towards early morning. That indicates that your asthma is not under control. Or everything goes well, I am blowing around 300 liters every day for the last 1 week. Suddenly I am getting a cold, or a virus cold or something like that, I am sneezing, and my peak flow is suddenly 150, from 300 to 150. So that is the time you should be alert that, so I am going to get a wheezing attack immediately. So that is what the time you must approach the consultant. So these are the two general broad outlines of these two equipments details.
Madam, this is a question to you, madam. Just like a peak flow meter and this thing for measuring the bronchial obstruction, I saw some device wherein they are able to assess the nasal block. Rhino. What is the value of that, madam, when to monitor the allergic rhinitis or nasal block?
I have not used it, but it has been there, documented in the textbooks only. Not many of us are using it to assess the airway resistance or to measure it. I think only people abroad are using it. We generally go by the nasal endoscopy, in which we will be able to see how the level of obstruction is, where it is and whether it has got better. In the sense, has the turbinate reduced in size, or has the polyps responded to some kind of medical treatment, plus based on the patient's symptomatology.
Because this being a non-invasive test, I thought whether it will have any role in monitoring the treatment, because many
Mostly,
times the
yes,
patient,
yes, it has been documented in the textbooks. Now, when they want to do a comparative study, that is what they do. So we don't have it. I've not
and
done it.
the classification you have made it very simple, intermittent and persistent, madam. And even in the persistent, how do you rate mild, moderate, severe? Because when they come with a diagnosis, some of the patients, mild, moderate, severe, is it only by
it is based on the other factors, that is the sleep disturbances mainly, and whether their day-to-day life parameters are being affected by this is what is actually putting us into the mild group or the moderate to severe group. If the sleep disturbance and the day-to-day activities are not being impaired, then the patient is into the mild perennial group. But if they are impaired, because then they fall into the moderate to severe group.
Okay. Dr. Emmanuel, would you like to add anything? Before going into the regular guidelines-based treatment, how do you manage the patient when they come to an emergency? Because it is most of the time emergency asthma, acute severe asthma, they don't go in search of a pulmonologist. They will land up with an emergency setup in any hospital. How do you receive them? How do you manage them?
I think I can put this question back to the audience, and I'll just give you a scenario. Patient is a known asthmatic, patient coming with breathing difficulty to the emergency room. How will you clinically assess the patient? First is assessment. Patient is dyspneic. You need to do a very rapid, quick assessment, because you need to start the therapy as early as possible. So what you are left with is maybe a few minutes. 1 to 2 minutes will be the time. I'll give you 2 minutes time. You need to assess the patient's severity. So what are the parameters you look for? Excellence. Is the patient able to complete a sentence? So why that's it's good that you told that first. Now why it is important? Does it have any clear correlation internally? Excellent. You opened up it in a very good way. Is the patient able to complete sentence? Is not able to complete. It correlates with? Yes? No. Well, it correlates with a specific internal parameter. Studies have come out. Again, I will appreciate the National Institute of Health for the job. We had many reproducible data done in India 20 years back, which proved that it was the same in the Indian population. Yes? 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 Be loud. Nobody is going to fail you if you are wrong. Yes? No, it doesn't correlate to oxygen. Something else? Huh? What is the level? Okay. That correlates, yes? No, it correlates with a PFR of less than 100, right? Some literature even tell it's 50 liters, right? So that is the correlation it gives you. So known asthmatic coming with, your patient is not able to give you the history, not able to complete the sentence, you think of a severe exacerbation of bronchial asthma. 1. What are the other parameters? You need not go beyond that. You know that the patient will be quite often in respiratory distress, and what are the things specifically you look for in the clinical examination? Few points. Yes, first, cyanosis, but rarely patients are cyanosed when they come to the ER. If they don't treat them, they will get cyanosed over a period of time. But quite often when they come to you, they are not cyanosed, at least adults. I am not sure about the pediatric. Yes? Yes, patient is in dyspneic, obviously. Something more than that? Can you give me a very simple method of detecting pulses paradoxes? Very simple method. It was a traditional method which was followed historically in identifying that. The pulse will collapse when the patient chest comes out. Okay, you won't feel the pulse when the patient chest comes out. That's a very simple method. Most common cause of pulses paradoxes are both seen in the ER and which we overlook. Okay, something better than that? Yes? No, it won't be there most of the time. Okay, you very good. You assess for the mental status of the patient. Why you need that, madam? Well, the patient who's no, why you need that? It's very critical from the treatment angle. The patient is drowsy, dozing off. Yes? No, from the treatment angle, how it helps? No. You cannot do anything for him. You cannot nebulize the patient. You cannot use NIV in that patient. You need to be more aggressive in the initial. He may need a mechanical ventilation, quick ABG and a mechanical ventilation at that point of time, because implant ventilation is a contraindication for NIV. Fine. Now, why I ask this question is that there are not much signs you can actually use. When a patient is not able to complete a sentence, heart rate is more than 120, you auscultate for V's, sometimes it can be a silent chest when it's very severe, then you go ahead with the treatment. You decide on the treatment. Okay, what is the principles in the treatment? You decided to treat. Before that, what is that you will do first? Before you have to give oxygen. Good. So what is that you will keep you will monitor the saturation. So what will be the target you will keep at? Now what is the target SpO2? You will titrate. You will start with the nasal cannula or facial mask. Yes. You will maintain somewhere around. Good. 90 to 95. So keep the saturation well. Then you go to the therapeutics. What are the things? So can you tell how you nebulize? With the dose? Yes, the postgraduates. You would have nebulized multiple times. So what is the drug you will opt for? Salbutamol? Okay. What is the milligram you use? Automatically get arrested. Okay, use 1 ml, which is 5 milligram. Right, fine. Then, do you add anything to that? Okay, fine. Do you nebulize only with salbutamol, or is there any benefit? Ipratropium. What is the dose you will add there? The recommended dose is 500 microgram, which is not 1 ml, it's actually 2 ml. Okay, now you nebulize over what period of time? 15 to 20 minutes. Done. Assessing, no improvement. What will be the next? Okay. Okay. Very good. How many times? Second dose you have given. 40 minutes is over. Okay, fine. Anyway, you have done your part. I will do my part now. In the initial part, I will just put a word to the bronchodilation alone, and they will give the mic to the others. Now, there are two methods by which it can be done. One is the intermittent method, another is the continuous method. We had some data on that. Our ERPG did a study on that. It didn't work out well, but we learned a lot of things in that. One is the intermittent dosing, where it's right you told that ipratropium is added, because though it's a slow acting drug, it helps in the subsequent accentuation of the drugs which is used. So the recommendation is that in the intermittent you use 5 milligram of salbutamol with 500 microgram of ipratropium bromate, give it over 20 minutes. Second dose can be repeated. So the first hour you can do it 3 times, right? Ensure that you are oxygenating the patient adequately. Another method is the continuous method, wherein it's actually recommended in some of the books now, give the 15 milligram over 1 hour, but I am quite skeptical on that continuous method for 2 reasons. One is the method what we use is jet nebulization. There is another method which is called mesh nebulization, which actually what it does is that it makes the form more fragmented, and the aerosol form is more smaller, so it reaches the airway well. So in India, we do not use mesh nebulization. Any of the centers you see, what we use is the jet nebulization. So in jet nebulization, though literature is claiming to continuous nebulization, better to go for intermittent dose. The first hour plan will be, as you rightly told, 5 milligram with 500 microgram of ipratropium, 20 minutes, 3 doses you give, right? So at the end of it, you will assess the patient. So at the end of 1 hour, you will be in a position to make a decision whether to continue it at a frequency, lesser frequency like hourly or second hourly, or go for methods like non-invasive ventilation, right? So this 1 hour is a time which they are framing. And one word here is that I give you also levosalbutamol and salbutamol, which you will select. How many of you use levosalbutamol? Can I have your hands up? Okay, 1 or 2. So I am giving you both. I am giving you salbutamol and levosalbutamol. I will leave the option to you to use one of them. Which you will select? Okay, since you have not used, you will be comfortable with salbutamol. But why I want to clarify is because initially when the drugs levosalbutamol came into the market, the claim was it produces the bronchodilatory effect at half the dose of salbutamol. So when you give 5 milligram of salbutamol, you give 1.25 to 2.5, it helps. This was the initial data, right? Now over a period of time, because markets will be able to push it only in the initial part, when community practitioners keeps using it over a period of time, the national data will evolve, and that will tell the truth many times. So actually, as per the current data, just come out 2 years back with the head-to-head Cochrane review, There is no significant difference in any way. Side effects, tachycardia, risk of arrhythmias, there is no significant difference. So I think I will stop with that.
No, very simple way, asking for some test. How will you see any asthma exacerbation, acute severe asthma, whether it is a cardiac or infection? How will you refer it to the patient for a BNP or a procalcitonin?
I think it's a purely physician point. It's when you will order for BNP.
Order for a BNP or a
I'll just ask one simple thing. How many of you have thought of heart failure when you see a patient with acute exacerbation? Can your hand up? I have only 2 hands. PGs, you have never thought of heart failure when you handle a patient with? You have thought? Okay. Yes, this is a... Yes. Now what will you do? When you think that the patient is having possible heart failure, what will you do? Why you think in the first place? What makes you think that the patient may have heart failure? Okay, you get cardiology patient. Okay, so people have comorbidities like, fine, okay. Any other reason, the postgraduates, what will make you think that this patient may have a cardiac illness? Yes? No, both will have breathlessness. Cardiac patients can have wheeze. Previous history of heart failure, good, excellent. Clinically at that point of time. Elevated JVP, okay. Now I will tell you the problem. The problem is in both in the clinical evaluation as well as in the investigation, because we keep seeing, and I have crossed nearly 10 years of breaking my head with such patients. When a bronchial asthma patient has concomitant heart failure, you won't be able to see a JVP because his axillary muscle will be so tightly acting. Whatever you do, you won't be able to see the waveforms there. The muscles will prevent you seeing the waveforms. One, gone. Second thing, will you be able to look for the S3? The lung will come and interfere with the interface. Heart rate will be pounding at 120 beats per minute. You won't be able to make out an X3. So the only clinical clue which some literature have actually highlighted is the basal fine crackles which overlays the wheeze or the crackles which you get in bronchial asthma. So basal fine crackles is probably the only clinical clue you can think of the possibility of a concomitant heart failure. Now the question is, how many of you have used BNP or at least know that BNP can be used? Okay, we have BNP for nearly 8 years in our institute, and I admit that it is causing more confusion in clinical practice rather than clarification. I'll tell you the reason why is because the literature on BNP is quite interesting. Any patient with breathlessness, you will have a BNP and drop it done. I will have a mind that I should not see BNP first until I see the patient. That should be the first thing because it will confuse my clinical opinion. Now, few points on BNP. The one thing is that in patients with acute severe pain, patients with long-standing asthma, there is some data that patients who fall into the category of severe persistent bronchial asthma, 1/5 of them have elevated BNP, irrespective of the pulmonary artery pressure. It's a data which you should be aware of. Why I am telling this? Because when a patient background severity is severe persistent bronchial asthma, when he comes to the ER and he has basal fine crackles, you can, if you suspect heart failure, you don't ask for BNP, you very well treat it for heart failure. It's the simplest thing you can do because it's likely that he may have a slight elevation BNP. His value may be around 100 as a cutoff. His baseline value itself will be somewhere around 200 or 300, and a value of 700 or 800 will not tell you anything. But it has a role if the patient baseline asthma falls under either mild persistent or moderate persistent. It's likely that he will have a baseline BNP which is normal, and at that setting you can use, again, what BNP level will help you, that is heart failure, at least 5-fold elevation from the base. For example, 100 is a cutoff for heart failure, that is for stable patients. So if it's more than 500 in a patient with background history of mild persistent or moderate persistent asthma, then you use BNP. Otherwise, severe persistent, you can straight away go and treat rather than bothering about that. Procalcitonin, I just put a word and stop with that. It's a very good tool which has come out now. Actually, it is a pro-hormone of calcitonin, and the cost of procalcitonin is now somewhere around 1,200 to 1,300. It's expensive. Provided a day will come when we are working on CART test which cost around 100 rupees, and that is supposed to get elevated in infective exacerbation. So deciding antibiotics, it will help you, but I think the cost has to come down. As a physician, I keep talking about the cost because we have no other option. Patient will have 8 problems and I have to balance. It's not only asthma, you will have CAD, CKD. So his pocket will be always there in my mind. So maybe procalcitonin is too early for us to use now. The cost comes to maybe 60 rupees, 100 rupees, maybe we can use it, but it's a good tool.
So, having finished with the acute asthma management, Dr. Dansegar, I think you should talk about the guidelines based or step up, step down therapy.
There are guidelines for treatment of bronchial asthma, but usually the guidelines, I don't think usually all of them will follow the guidelines as such. The GINA guidelines, where according to the classification, it depends upon the level of FEV1. It's classified as mild, moderate, mild persistent, moderate persistent, and severe. And in that, it depends upon the FEV1 level, and it also depends upon the variability. Variability means if there is a variation between morning and in the evening, the variability of more than 20%, then it is denoted as bronchial asthma. So in that category, they have classified into it. In mild persistent, only inhale bronchodilators like salbutamol whenever needed is sufficient. Sometimes you can add leukotriene antagonist in that type of cases. In moderate persistent and severe persistent, we have to go for a step up and step down therapy. That is, step up means you have to go for a high dose of inhaled steroids, and once the symptom has improved, followed by the symptomatic improvement, if there is an improvement in the FEV1, then you can gradually taper the dosage of inhaled corticosteroids. That usually we will go for a budesonide formoterol combination, or a salmeterol budesonide combination, or sometimes salmeterol or fluticasone combination, depending upon the I usually prefer formoterol and budesonide combination, and this because why this has a very short duration, very onset of action is very fast in case when compared with salmeterol. This formoterol has a very faster action, and the symptom relief is better when compared with salmeterol. And usually we will go for a 2 puff in the morning and 2 puff in the night, because it has a long duration of action, and up to 800 microgram, there is 200 microgram per puff, totally it comes to 800 microgram. 800 micrograms of inhaled corticosteroids has no such a bad effect on the, it won't affect the axis, so it's better you can go for a higher dose, and then once the patient improves symptomatically, as well as when the FEV1 has come down, you can step down to 2 puff in the morning alone, or in the 2 puff in the night alone. According to that, you can taper. Most of the time we won't follow the guidelines, mainly we follow the symptomatic treatment. In India, I don't know how much Dr. Venugopal sir will be elaborating in detail about that adoption of guideline treatment.
Guidelines practice actually is only for academic purposes, but usually in all the pulmonology departments, most of the physicians, most of the pulmonologists, they taper the dose or increase the dose according to the response of the patients. So guidelines practice usually we do not do.
Dr. Thangavel, would you like to add anything? Dr. Dansegar has told he prefers formoterol to salmeterol, but somehow I see more pediatricians, they prefer salmeterol more than formoterol. But as Dr. Dansegar has told, salmeterol, when you increase the dosage, the toxicity becomes more. Whereas formoterol, if you increase the dose, the therapeutic efficacy is more. In that way also, formoterol is little superior to salmeterol, but I don't know why the pediatricians, they prefer salmeterol or formoterol. Do you have any specific reason?
Not very commonly used, sir. Most of the time, salmeterol and formoterol used only by the pulmonologist. Only children in the later age group where they continue to have chronic persistent asthma. Most of the time they settle with either leukotriene antagonist or even older drug like budesonide and fluticasone, they settle most of the times.
So
very rarely they go in for
so
formoterol.
pediatrician, you don't use the LABA?
Not commonly used.
Commonly used.
But we have more problem with acute severe asthma only. I just want to tell you two things about acute severe asthma. We prefer more of using spacer and mask, spacer, mask and puff rather than nebulization. Because I think just I want to add with what Dr. Emmanuel told it. When you nebulize a child, it has to be along only with oxygen. If you don't give along with oxygen, if you nebulize a child only with salbutamol or ipratropium, it might cause a paradoxical vasoconstriction, might worsen the situation because of the protective effect is lost. So most of the time we use the in mild and moderate asthma, except acute severe asthma, use only spacer and puff is almost 6 puffs of salbutamol is equivalent to 1 nebulization. To compare that last 20 minutes, 5 milligram, it is only 600 microgram, each puff is 100 microgram. 600 microgram in 2 minutes is almost equivalent to 20 minutes usage of salbutamol with a crying child. Invariably that precipitates hypoxia. That's one thing. Second is, I think in adult practice we don't use adrenaline. Adrenaline is still very commonly used in acute severe asthma practice. Children. Very commonly used. Particularly life-threatening asthma. A child comes with almost, as Dr. Emmanuel said, no air entry, sweating, bradycardia, bradypnea. Next 1 or 2 minutes he is going to collapse and fall down. Nebulization will not work because it won't go into the, such a low this thing, it cannot go into the lungs with severe vasoconstriction. There we use subcutaneous adrenaline. Only that we exclude cardiac conditions. Of course, it will obviously may be able to differentiate a cardiac from a respiratory status. Where we use 0.01 milligram per kilogram of adrenaline, undiluted adrenaline, subcutaneously makes great wonders. Within 5 minutes, child will be relieved of the asthma. Even before you refer the child, you can give the subcutaneous adrenaline. So this salbutamol puffs with spacer and mask is more frequently used in OPN clinic than in nebulization.
Emmanuel, you can just add about the safety of this LABA in a cardiac patient.
Yeah, it's actually a very big concern nowadays. People reading the internet, they come and ask you that you're prescribing this and there is some cardiac concern on that. Let me just make a short review on that. Before that, like sir told that subcutaneous adrenaline, older books if you see it is there, even in adult medicine we have been using it. And after 1980,
but they should not try to do it in their clinical practice. It's not be done. It should be done in a setup.
After 1980, what happened? There were a lot of data coming on cardiac safety on adrenaline use in adults. So around it's children is completely different. But in adults beyond around 1990, there were a lot of repeated publication again from the Canadian NIH and Australian NIH. That was the exact point where it was removed from the guidelines. Where in adults in the field practice they discouraged it because increased cardiac deaths, especially after the patient got discharged. You would have received adrenaline in the emergency room, gone home and then developed a coronary event. So there was a reason why it is out of the adult protocol, at least in the first line, maybe somewhere in the bottom it's given. Now regarding the cardiac safety, and now please take me that I am not supporting any sponsors, but I'll just review the data on both the long-acting agonist, the formoterol and the salmeterol. Lot of data is there on COPD. We know to some extent that the cardiac safety is a big concern in patients with COPD whose age is higher. Whereas in bronchial asthma, if you look at the last 5 years, there are the few systematic analysis. There is one Cochrane review on the topic also, where they have looked into the cardiac safety of these two drugs. Now overall, if you ask me a single answer, the evidence points towards the possibility that formoterol is less cardiotoxic than salmeterol in the long run. Okay, this is, if you ask me a single conclusion, I can tell that, again telling that I am not supporting the sponsor for that, but I am telling you what the evidence says. Formoterol, the long-term cardiac safety is better compared to salmeterol. But I will also tell the problem with these studies, because they have not looked into the risk factor profile of the individual very clearly. They are all cohort studies on a large group where the risk factor is not very clear. The second one is that the cardiac adverse effect is related to what is called polymorphism to the beta adrenoreceptors. It is a genetic polymorphism to the beta adrenoreceptors, and what we know is that the African Americans have a high bad pleomorphism, high cardiac events, whereas whites they relatively have less. So we do not know the genetic polymorphism in our setup. So given the so much complexity of the cardiac safety of LABA and bronchial asthma, maybe at that point of time you can take home that probably formoterol is better than salmeterol from the cardiac viewpoint. More has to be learnt about the cardiac safety.
Okay, this question is for madam, because ENT people are the people who advocate this immunotherapies, allergic, more, maybe not you, your colleagues.
During my presentation, during my presentation itself, I told that my exposure to immunotherapy is very less. In fact, I was talking to 2 or 3 people yesterday regarding the immunotherapy that has been tried out in India. And not many ENT surgeons have actually done it, and there is only 1 or 2 pulmonologists in Chennai who are practicing it. So we have not actually referred patients even for skin prick tests. It has all been documented that these are the investigations that needs to be done. But if you actually send a patient for a skin prick test, they come back and tell me, is this what you did? To find out that I am allergic to 10 different kinds of substances, which I cannot avoid in day-to-day life. So unless we are going to advocate immunotherapy, skin prick tests, I think we should just keep it on hold unless the patient is very specific and have only 1 or 2 allergens. So my knowledge on immunotherapy, if I can ask the question back, is there any experience, then I would be helpful.
The thing is, actually, it has got no role, madam.
Yeah.
Because maybe some 1 or 2 of them they practice, but BMRC guidelines clearly states that immunotherapy has got no role in the treatment of bronchial asthma. He has even not mentioned about the homeopathy, acupuncture, all those things, because they have not conducted any controlled trials on acupuncture and homeopathy treatment for asthma, whereas they have conducted studies with immunotherapy. So they clearly advocates against it.
And it's only useful in seasonal allergy. I think not at all in perennial allergy. In seasonal allergy, I think it's only the pollen. So if that is the case, then it may help those patients, but not many of our patients have specific pollen allergy. We don't have that kind of a seasonal variation in which patients specifically come to me saying that I have this kind of an allergy in this season. So for these 2 things, I think immunotherapy and seasonal allergy, we are not anywhere there close to what the literature and evidence have been telling us.
So I think all of you forget about this immunotherapy. Then regarding this investigation, one thing is this nitric, instead of doing because the PFT, as we told, it is effort dependent. The patient cooperation is very important. Although we are talking about the cost, we are talking about the setup, all those things. But the most important is the patient has to understand and do the test properly. But there are some tests now available which doesn't require the patient cooperation, wherein you can monitor the inflammation. After all, asthma is an inflammatory disease in the bronchus. I think Dr. Dansegar, he has got some instruments in his play. He is the right person to answer.
The role of exhaled nitric oxide in bronchial asthma, that is, it's a simple test which will measure the airway inflammation. But till now I have done around 100 patients, mostly around 100. And I found that it's not correlating with the severity of the airway disease. Because most of the patients who are put in for exhaled nitric oxide simultaneously will be doing a pulmonary function test also. In that type of patients, if you have, some patients will have a severe airway obstruction by PFT, but the exhaled nitric oxide will be normal. But sometimes the patient will have a normal airway, normal PFT, but the exhaled nitric oxide will be very high. But I don't know how to correlate this, and it's mostly followed mainly the exhaled nitric oxide is helpful in the follow-up of the patient while on treatment. That is, if you put the patient on inhalers and on oral steroids, and you can review the patient after 3 months and you can find out the airway inflammation has reduced or not. That shows you whether your treatment is working or whether the patient is taking the inhalers regularly. That is how it is helpful, and it's most commonly used in pediatric age group. I think sir has to has any about exhaled.
Not also. We don't have any experience because none of us, and both in government and private, we are still in the discussions point of only.
Bhaskar,
we don't.
Emmanuel Bhaskar.
I have no clue about it. First concern is again the cost.
No, the cost is very high.
Until the diagnostic test is somewhere around 400.
The exhaled nitric oxide, the cost of the test is very high because you have to use a filter for each patient, and each filter itself costs around 250 rupees. And this machine will be only you can do up to 50,000 tests. After that, you have to change the machine and you have to buy another one. So it's a costly affair, and I don't think till now I have not found any correlation in between the PFT and the exhaled nitric oxide. I don't know to read it now. Maybe in, if I do more, whether it's coming out correctly or not, I can tell you.
So you won't buy the next machine, sir?
Definitely.
After 50,000.
Are you able to pay your dues, bank dues at least? Anyway, okay. Anyway, I think we had a fairly good discussion. We will end up with some word about vaccines, because adult vaccine, pediatric vaccine, vaccination is a
Vaccination is the bread and butter of the pediatrician. As for now, 30 years back, when microbiologist told future pediatricians are going to be immunologists or vaccine specialists. That's why most of the pediatricians now, 1/3 of the patients come only for vaccines. Number of vaccines are increasing day by day, but mostly children with asthma, they may require, we categorize respiratory vaccines, starting from BCG, even on 3rd day. And then DPT is routinely given 3 doses, first booster, that is again a respiratory vaccine like prevents pertussis. Measles is very important disease, now coming back. We started seeing measles disease has been supposed to be eradicated, we started seeing more measles. Another important vaccine, influenza vaccine, and now pneumococcal vaccines are also available. We generally tell the children with chronic wheezes, we ensure that we give this vaccine so that every respiratory infection is going to worsen the situation. These are considered as respiratory vaccines.
give you 3 minutes, sir. You can vaccine and other things running.
I will share with you the data. Share with you data on the Ministry of Health data, which we, a small thing, we did a cohort of the military colonies in North India. Now, what was the observation was that these cohort were administered both pneumococcal vaccine and influenza vaccine, and it was somewhere around 2009, exactly the time where the pandemic influenza was going around. It was a 2-year cohort which was looked into. It was a crude observation what we have made. Some few about entire cohort, if you take 6% were asthmatic. So I just after the invitation I just got back to them and got some data on that. Now, one thing we understood is that the influenza vaccine definitely helped asthmatic patients, because if you look at the number of exacerbation, people who took, it was only on a voluntary basis, not every asthmatic took it. People who had taken the vaccine from 2009 to 2013, the number of hospitalization were less, though it was not statistically significant. If you look at the absolute number, it was less. Whereas pneumococcal vaccine, irrespective of whether they have taken or not, it did not correlate with the hospitalization. So it's just a preliminary thing. There are data in the West telling that more benefit is with influenza vaccine rather than pneumococcal vaccines. Actually, what they tell is that if the children are vaccinated with pneumococcal vaccine, adults get benefited. Yeah, so that's more convincing.
Probably it is a virus that is virus versus bacteria. That's the issue. Would you like to say something? Very good. 2 minutes. Anything?
See, the pregnancy as well as
one more thing, Dr. Then say you went for some training for this bronchial thermoplasty. You can also just mention it's for the benefit of the postgraduates. Role of thermoplasty in asthma. That's the future.
See, you have to treat bronchial asthma as a normal person if the patient is pregnant also. So there is no change in the treatment, like whatever you are giving for an adult, you can give for the pregnant ladies. Only thing you have to be more careful in this is you have to avoid leukotriene antagonists, and oral preparations you have to restrict as much as possible. Inhaled preparations are safe and you can use along with that, and you have to weigh the thing, because the hypoxia is more dangerous than the drug what is going to the side effect of the drug. So I don't think any change can be done except the leukotrienes and certain leukotrienes you should not give.
No. The British National Formulary clearly says that if a patient is on leukotriene antagonist before pregnancy, and if she gets pregnant, you can continue. They don't advocate stoppage.
No, only during the pregnancy.
First startage of leukotriene antagonist, maybe you must be having.
In pregnancy and asthma, treating the reflux, GRD is one of the major things. When a pregnant woman is not responding to asthma therapy, think of GRD. It's very common. Even otherwise, hyperemesis reflux is more common in pregnancy. So that could be the trigger for the thing. So that is important. And after all, most of the PPAs are quite safe in pregnancy. Is there any?
Yeah, if you look into the FDA thing, if you look at the PPA, now it has come through. It has gone to FDA category C to B.
So
okay,
all
so
the PPAs
that's not
are
a
safe
concern.
in pregnancy.
PPA can
so
be given.
I think give them a PPA. That will definitely help them.
One thing I want to add is that vaccination is very critical in pregnant asthmatics because the mortality due to influenza in pregnancy is very, very high. It is somewhere around 30 to 40%. We saw the brunt which it had in 2009 and 10. We had a separate intensive care for influenza. It just kills. Okay, so vaccination is very important. Influenza vaccination pregnancy is very, very critical.
The final thing is about the bronchothermoplasty. That is, where we do bronchothermoplasty is mainly in a fixed airway disease, where if the patient with bronchial asthma, which is a reversible airway disease, once they go for an irreversible, that is, if they go for a fixed airway, where they will go for an airway remodeling and thickening of the airway, in that type of cases, the bronchothermoplasty is helpful. But it is all under trial, but it has not been come as a routine procedure for all fixed airway disease, where we will go with the bronchoscope, we will put the incision like with the electrocautery, and then we will separate the muscles. That's called as a bronchothermoplasty. That is not fully proved, and it is not coming as a routine procedure for fixed airway disease.
I think we had a fairly extensive discussion on that. You have any questions? We will take it. One by one.
Like somewhere in 12 years has the asthma. Is cognitive function means like its performance in the school will be increased, or what will be that, sir?
Yeah, it depends. If they have a repeated hospitalization, only then affects the cognitive function. Repeated hospitalization, repeated ER visits, a child requiring ICU admissions. Apart from that, they are fairly manageable because drugs available now, inhalers are very good. So most of the time, the cognitive functions are not affected.
No, sir, in other way, like I heard in articles, I read an article that the persons who have this IgE level more, that intelligence will be more. So comment on that, sir.
Now, IgE is a very, very non-specific test. In a country like India, where we have a lot of worm infestations, even the IgE cannot be taken as an evidence of hyperactive airway disease. So, it is very, very, very non-specific.
This that one part we have, I think we have left. This IgE level has to do with only allergic bronchopulmonary aspergillosis. That is one form of severe asthma. When the asthma is brittle, when they are not responding, we are talking about GERD, allergic rhinitis, comorbid like that. That is one thing is allergic bronchopulmonary aspergillosis, wherein the IgE has got a role. Routinely doing an IgE level for all asthmatics, I think it is not warranted. Where is the need? Even our ENT colleague, she agrees with that, because routinely there is no point in doing an IgE level. And there is a lot of variation. I found a patient coming with 3 or 4 levels of IgE. Different labs give different values. I don't think it has got...
And in any patient with bronchial asthma not responding, and in an X-ray who is having fleeting pulmonary shadows, if you took a total IgE, it will be elevated. And you have to do a specific total aspergillus specific IgG and IgE. If that is also elevated, along with there are minor criteria and major criteria, along with that you fix it as a diagnosis of allergic bronchopulmonary aspergillosis. In that case, the main aim of doing total IgE is to find out you can do every 3 months or 6 months according to how much you are giving the steroids. To taper the level of steroid, you have to follow the patient with total IgE. That is the role of total IgE.
Routinely doing an IgE for an asthma management is not warranted. Second, here from...
Yes, Dr. Dhanashekar, do you still use IV doxycycline for acute exacerbation?
No, I have not used.
For Frontier you had used, sir. I was
Previously I was using, nowadays I stopped using, because previously we give 200 micrograms, 200 milligrams continuous infusion for over 20-30 minutes. Okay. But previously they were using aminophylline, but the doxycycline IV now I stopped using because of the inhalers getting a better than
what about subcutaneous terbutaline?
No, I have not tried.
No, so giving an IV derifilin will be the best thing during acute exacerbation?
No, see, in injectable preparations, it's better to be avoided because they are more cardiotoxic.
Yeah, sure.
So it's better to avoid. But whereas the doxorubicin has a little cardiac effect when compared with aminophylline as well as other preparations. But nowadays we won't give any injectable part. Now they have stopped producing the injectable doxorubicin.
Okay. There was a tablet known as prenoxidazine at one point of time. I think it was prenoxidazine. It was used for this cough variant asthma at one point of time. I think it is Aristo Pharmaceuticals which was manufacturing it. I mean, is it still used? No idea. Madam, one more question to Madam. Madam, you had a picture of a cat. You said that you could avoid this, avoid such allergens. I had read at some point of time, like if you have a family history of atopy, if you expose the child to, such allergens, then they will not develop asthma. Is it true?
So that means you're trying to sensitize the child.
Yeah, exactly.
So if you're doing that and the child has a background of allergy, how do you know that it's only because of the cat?
No, I'm just asking, for example, family history, the father was exposed, there was a cat in the house exposed to cat fur and all. Now the child wants to have a cat at the home. And this exposure, will it help,
during sensitization, if you actually look at the exposure to allergens, it is definitely not one. I think it would be at least 4 or 5 at one particular point of time. So exposing the patient to only the cat is not going to sensitize the entire group.
My cat, that was an example. I saw the picture, that's why
Yeah,
I just
yeah,
asked you.
No, actually,
specific allergy I want to say.
Can I add a point on that?
Yeah, sure.
If you can show, I can show you data which shows that exposure to allergen causes asthma during adulthood. I can show you equal number of data which shows that not exposure to allergen protects from asthma. So actually it's a big divide in the immunological epidemiology. So if you just go and Google it and see, just put both the words, you will get adequate number of data on both sides. I think immunology of asthma, we have to learn more and more. What I have learned is a very small fraction of what is really happening in the body. Okay, now, okay, fine. And again, it's a data where IV magnesium, I can straight away tell that I just did the review on the last 5 years. Last 5 years, there is no big change in the recommendation. Still, they do recommend magnesium sulfate in refractory asthma. And whether it helps or not, whether in the long run it helps, what it actually does, thing is not settled. So last 5 years, the recommendation of magnesium sulfate has not changed. You can still use it in refractory asthma. Fine. Whether it works or not, it's not clear. As far as IV steroids is concerned, there is, I think you are asking a debate between IV or oral steroid. I think it's a better way to put it across. If you look at the guidelines and if you look at the studies also which has been done on that, they keep telling that steroids, either you give IV in the form of methylprednisolone or hydrocortisone, or you give prednisolone in the form of 60 to 80 milligram, they are the same. Okay, this is what the guidelines keep telling. If you go back and see what was the basis of these guidelines, if you look at published studies, studies have looked into difference between oral or the IV steroids at the duration of hospitalization or mortality. These are the two things they have looked in. What they have not looked in is the improvement in symptoms in the first 72 hours. If you look at the experts who argue that IV is always better than oral in the acute setting, they will always put this point first. Data has not seen whether the improvement is better with IV in the first 72 hours combined with oral. Okay, so I think there is a lacuna in the data itself. So what I personally feel that IV methylprednisolone at a dose of 125 milligram 6th 8th hourly or hydrocortisone, or for that matter any steroid, I don't think there's a big difference. Initially for the first 72 hours does help in decreasing the duration of symptoms, getting back the patient to a normalcy. On the long run, I think it can be used. Again, inhalational steroid, data is quite clear. Using it when you use IV steroids is not that beneficial. But when you discharge the patient, you are putting the patient on an inhaler and switching and on oral steroids, that point of time inhalational steroid will help in the switchover. So IV steroids predominantly in the initial phase, and inhalation steroid in the later phase along with all will be my take on the steroids.
Sir, regarding inhalational steroid, what would be the steroid of choice?
In the acute setting, budesonide is the most well studied, madam. The dose is 1 milligram, 4th hourly, even 3rd hourly can be given. Budesonide is the most extensively studied steroid.
In long-term management of the patient.
Long-term steroid, there will be a better option to tell, but I will still stick to budesonide and the fluticasone. The fluticasone is more well studied in the long run. The inhaler preparation, fluticasone has the largest data, whereas in the acute phase, budesonide has the largest data, as far as the evidence is concerned.
Pediatric population, I agree with Dr. Emmanuel. Maxil still plays a role. After 3 nebulization of the child does not improve, we always go for magnesium sulfate. It is a very safe drug. It is also still found to be a quite useful drug. 1 dose of magnesium sulfate will prevent the child entering into ICU. And regarding the steroid, the pediatric study says that if the child is able to take oral steroid is almost equivalent to the efficacy of IV steroids. And rather practical difficulties, 1 milligram per kilogram for 1 milligram per kilogram body weight of methylprednisolone, I had to open a big vial to give only 10 milligram. That may not be practically viable. So generally we prefer to give oral steroid as long as the child is able to take orally. Only the child is unable to take orally, then we go for IV steroids.
Sir,
And pediatricians still go with the older rules. Still we use, sir was discussing about, still we use IV aminophylline, IV terbinafine infusions are quite commonly used and child goes into high dependency unit or ICU. Still we depend on that. They are quite safe options in pediatrics. Particularly aminophylline, we got a very long experience. Even the recent guidelines say that aminophylline is definitely better than terbinafine. Only the side effect profile is little more higher for IV aminophylline because of neurotoxicity and cardiotoxicity. So IV aminophylline, IV terbinafine is still used in pediatric acute severe asthma, getting admitted to ICUs.
Bhaskar, the role of macrolides.
Any inhaled steroid is good, madam, because even all over the world, if you see, 50% of the inhaled steroid is beclomethasone still. Still 50% of the inhaled steroid market is beclomethasone. We don't use here much, but in New Zealand, Australia and UK, it is a beclomethasone that is widely prescribed. It's okay. The next commonly used is your budesonide and fluticasone. But slowly the things are changing. Now it's more, shift is more towards budesonide from fluticasone, generally. Otherwise, anything is good, but only thing is, they should be on inhaled corticosteroid, not on oral drugs, when it comes to long-term management of asthma.
One more question, sir. Where to exactly place a leukotriene antagonist in the management of asthma, long-term asthma?
This is more helpful in exercise-induced asthma, and in case of refractory asthma, if the patient is not responding, you can add in that type of cases. And atopic asthma, it's more helpful, and sometimes if the patient is associated with allergic bronchopulmonary aspergillosis, in that also the leukotriene as an add-on therapy in helpful in treatment. And Bhaskar, you just highlight on
seasonal asthma. Suppose a patient says every winter that he gets episodic asthmatic attacks. When exactly should we start him on preventive therapy?
Madam, there is no such thing. If you analyze the patient, there is no such thing called seasonal. The patient gets worsening of the symptom. That is why they come. Even in the absence of symptom, asthmatic is an asthmatic.
Throughout the year, he has to be on preventive.
Even if the patient is normal, you send him for a PFT, he will show obstruction, reversibility will be there.
It will be subclinical, madam, we are missing it.
It will be under him. It is just like taking a patient, oh, I don't have giddiness, I won't take BP medicine. It is just like that. Our asthmatics, they cheat themselves and they cheat the doctor also, telling that I get only once in a year, only during Deepavali I am getting. All those things are all wrong concepts. They will have asthma even if they don't have symptoms. So they have to take, they should be advised to take medicine even in the absence of symptoms. That is where the spirometry plays an important role, making a definitive diagnosis of asthma. If you suspect asthma, do a spirometry, make a definitive diagnosis, educate the patient that they should take the medicine even in the absence of symptoms. That is the primary thing. Am I correct, sir?
Sir, I think sir asked about
the role of macrolides in
prevention. Sir?
Prevention.
Yeah, I think the big article came in New England Journal of Medicine. There are 3 or 4 studies going on macrolide. The studies have identified that chronic suppressive therapy, taking azithromycin on a weekly basis for a long time, prevents exacerbation. But a larger concern has evolved with antibiotic resistance, and I think 3 of the studies have been prematurely terminated in the US. So I think that may not be the solution logically. If you keep giving antibiotics, it may have cardiac toxicity on the long run. It may generate resistant pathogens. I think that logically thinking may not be the right way on the long run.
It has got an effect. Anti-inflammatory effect.
They have identified an effect,
yeah,
but
anti-inflammatory effect of the macrolide is the one that works. It is not the antibiotic effect, obviously. So when you have steroids, what more is required? Anti-inflammation. Steroid is the of all the anti-inflammatory, the best is steroid, inhaled corticosteroid. So I don't think that's going to help much more than that.
Just one point. I think this nasal polyposis, nasal allergy also, there is no remission at all. It would be just that the patient is mildly asymptomatic. they have to meet the doctor. Even if we operate on patients with nasal polyposis, we don't tell them that we are assuring you of a 100% cure. We are only treating you the present symptomatology, and you need to be under follow-up with us, whomever you want to meet or not. It should be an ENT consultation once in every 2 months, just to assess what is the status of the polyps, and if it is on the stage of a flare-up, we have to treat it then and there. I think allergy and allergic rhinitis, the treatment is, it will be there always, either a tablet or a spray or an antihistamine. The patient should always have it.
Same. You endorsed my view. Thank you. I think we had a last question. Okay. Exertional. Exercise-induced asthma. Okay. Same thing. Exercise-induced asthma also. I think for treatment for exercise-induced asthma on a long term is leukotrienes, he has told. But the best safe treatment is taking a beta-2 agonist. Just before, 20 minutes before, because it's salbutamol or levosalbutamol for 20 minutes before the exercise. That is the safest thing. I think we have finished with the thing. Have we exceeded the limit, madam?
No, sir.
Thank you.
Once again, I would like to thank the coordinator, Professor Rajagopalan, and all the panelists for this wonderful discussion on management of asthma. We would like to give a small memento to Dr. Thangavel and Dr. Emmanuel Bhaskar on behalf of Institute Hospital IIT.